that should be good. So I'll just get anyone who doesn't have their themselves muted, just please go ahead and do so. Um, I will open us up. So my name is Sarah Lovegrove. Pronouns are she and her. I'm the vice president of the Harm Reduction Nurses Association. The Harm Reduction Nurses Association does work with individuals and organizations across all of Turtle Island, and we honor the life force of Indigenous peoples who have had their land stolen and who continue to resist ongoing genocide. Addressing the root causes of the toxic drug supply is deeply connected to decolonization. And I am personally joining you today as an uninvited white settler on the traditional unceded territory of the Snuneymuxw First Nation, colonially referred to as Nanaimo on Vancouver Island. The content discussed today is made possible by people with lived and living experience of drug use, sharing their knowledge and experience, and without their generosity, vital life-saving harm reduction initiatives would not exist. So just a little bit about HRNA and a couple notes that our President Corey wanted us to share today. So the Harm Reduction Nurses Association is a Canadian national organization with a mission to advance harm reduction nursing through practice, education, research, and advocacy. Today we have a number of board members and HRNA members present, and we just wanted to offer the opportunity for any nurses, students here today. Our membership list is always open and you're always welcome to join with us. We also have associate memberships for non-nurses if that's something you're interested in. We continue to, we try to do webinars of a variety of resources and educational opportunities throughout the year. And we have an upcoming members only roundtable later this week or next week, I can't remember the date, sorry, about scholarship, primarily about the HRNA Chapman Harm Reduction Award. And this award is proudly presented by Dr. Lee Chapman, who is the Chief Nursing Officer of Canada and Harm Reduction Nurses Association, and is named for Lee Chapman, the Harm Reduction Nurse Association's first elected board members. This award recognizes a nurse, NP, RN, RPN, or LPN with experience working in harm reduction who is entering into or in the midst of a Canadian accredited graduate program. This award received inaugural donations, but we continue to fundraise to reach a threshold that will enable the award to be offered annually. You can donate or direct donations by going to our website and clicking on the banner featured stating make a donation in support of HRNA Chapman Harm Reduction Award, and just let us know in the comments of the donation that it's for the HRNA Award. So we're hoping to be able to support students and nurses in evolving education through that process. So without further ado, we'll get to our session here today. So we have Dr. Jessica Wilder here with us from Doctors for Safer Drug Policy. Dr. Wilder is a physician in family and addictions medicine, and she's also a fierce and compassionate advocate for our community's most vulnerable, specifically in harm reduction. Doctors for Safer Drug Policy is a group of physicians who care for people who use substances and are advocating for safer, more compassionate, evidence-based healthcare policies. I had the incredible opportunity of working with Jessica and the Doctors for Safer Drug Policy on a recent one of the recent and ongoing efforts with the pop-up overdose prevention sites here across Vancouver Island. And I had the opportunity to bring a number of my nursing students who are here with us today, as well as a group of students with the VIU Harm Reduction Alliance. And the experience was absolutely impossible to compare to any other opportunity that these students could have. And it was an incredible opportunity to just demonstrate how harm reduction advocacy and compassionate action can be translated into tangible action for change in our communities. So just a few housekeeping notes. We do have the chat open. You're welcome and always welcome to keep your video on, but that's not necessary. We just ask that you have a mute. If you have questions, Dr. Wilder's taking them throughout, and Megan Hicks and I will be monitoring the chat box for questions. Dr. Wilder is going to do her presentation and then open up the floor for questions afterwards and discussion. If anyone, if technology is not working or you can't hear someone, just please let me know. This is not intuitive to me, so I will try to correct as necessary. But You also want to ask your questions directly. Please feel free to ask, turn your camera and sound after the presentation and ask Dr. Wilder directly. Otherwise, I will hand it over to Dr. Wilder, and I'll try to share my screen now.
Thank you so much, Sarah. I'm really excited to see so many people expressing in the chat where they're from, what you do. All of you are doing such important work all across Turtle Island, and just seeing that you're all gathered here today to have more of a conversation about implementation of harm reduction in healthcare is really an honor. So there's obviously a lot of experience at in this group today, and I want to acknowledge I really do want this to be a conversation. So if there is any point during the chat that what I'm saying is too basic for you or not interesting to you and you want to talk about something else, I'm very happy to be flexible with this next hour. I'll talk a little bit about myself. So on the next slide. So I was originally born on Treaty 7 land in the Métis Nation, colonially known as Calgary. I grew up in the never ceded territories of the Secwepemc people, or Shuswap. Specifically, I grew up in what is known to white settlers as a tiny town called Enderby in the North Okanagan. And I'm currently residing as an uninvited guest on the ancestral and never ceded territory of the Nunemu people. I'm a family and addictions medicine doctor. As Sarah said, I currently wear multiple hats in both BC and the Northwest Territories. So while most of my work is in addictions medicine, I also provide family medicine. I do hospitalist work. I am a MAID provider and an HIV care provider, and one of the co-founders for Doctors for Safer Drug Policy. I think most importantly in this chat and in my work is that I try daily to approach my life in a way that prioritizes connection, practicing of radical empathy, and finding ways to continue to hold myself more accountable for the impact that I have on people and on the world around me. Some things that I would love for you to reflect on during this conversation is that I recognize we're in a place right now that the work that many of us do has become increasingly polarized and increasingly politicized. And we exist in systems where politicians have the power over what we have access to keep the patients and the clients and the community members that we work with safe. So in an effort to continue to hold myself accountable for how I can be participating in the change that we need to see within our system, I'd encourage you all to think about these questions over this next hour. What does safety in the healthcare setting look and feel like to me? And when I think about safety, whose safety am I thinking about? Is there a way that we can be thinking about safety that is that applies to everybody? What can I ask and expect of my healthcare providers to ensure that I can equitably and safely access healthcare? And how do we dismantle our current colonial systems of care to improve health and well-being for all? Sarah's already shared our philosophy here, Doctors for Safer Drug Policy. I'll talk a little bit more about who we are and why we formed, but the basics are that we're a group of physicians who work with people who use substances, and we are recognizing that we have drug policies that are not safe, and we're looking for safety, we're looking for compassion, we're looking for evidence-based policies, so ones that are not based in moral panic, and ones that can increase equitable access to our patients. We initially formed as a result of a number of things that happened in our health authority. Last year we had, an overnight decision by the government that led to the removal of harm reduction kiosks, which dispensed basic harm reduction supplies, wound care supplies, Narcan kits, fentanyl testing strips, condoms, bandages. And these were removed overnight as a political move by our provincial government. Then in the spring of last year, we were promised hospital-based overdose prevention sites at multiple hospitals across our island. And again, as a political move, the provincial government shut down this project. And 6 months later, as physicians practicing on the front lines of this work, we still had radio silence from the government, while 7 British Columbians continued to die every day as a result of this crisis. So after nearly a decade of policy failure, we as physicians, and I'm sure all of you here, we have not had the tools that we need to help keep people safe. And it has created an incredible amount of moral distress and moral failing that we are letting our patients down when really it is the system that's broken. So we're tired of grieving for the loss of our patients, and we're tired of helping family members navigate the grief of preventable deaths of their loved ones. And so this was really a response that was born from a lot of frustrations that built over time, and the realization that our systems are going to continue to have meetings and talk about what we should do, but we needed to take action and actually stand up and do something. So harm reduction, I mean, I'm preaching to the choir here as I look at all of the experience that we have in this group. So I'll go just briefly into this, but harm reduction as a policy and as something in healthcare in general, it's practice and policies that aim to minimize the negative health, social, and legal impacts that are associated with potentially harmful behaviors. Harm reduction with regards to substance use is grounded in justice and human rights. It attempts to disentangle the notion that drug use equals harm, and instead identifies the negative consequences that come from drug use as the target for intervention. So harm reduction acknowledges that drugs are not entities with fixed meaning. Our ideas about drugs are framed by the era that we live in. A really good example of this, when I try to explain to people about how perceptions of drug use change over time, is that in the 1920s, alcohol was prohibited. It was an arrestable offense. But then in the 1990s, it was totally acceptable to smoke in your home when you had young children, or to smoke in the hospital. And both of these perceptions are things that are so dramatically different to how we would respond to tobacco smoke exposure or alcohol use today. And if you could just go back one more, Sarah. I'm glad that you're having to navigate this because I don't know how to go forward on back or on Canva either. The most important part of harm reduction when I think of how it applies to my job is that it does not require that people have to stop using drugs as a precondition of support. I can't believe that this is something that I have to explain to some of my colleagues who are not as well versed in harm reduction as many of us are. But yes, everyone deserves access to healthcare. I'm a physician, not a judge, so it's not my job to weigh in on whether or not my patients engage in behaviors that are different than the ones that I may have, or hold beliefs that are different than the ones that I may have. It's my job and an oath that I took that I stand by to keep my patients healthy, whatever that looks like to them. This is way too basic for everybody here. Examples of harm reduction in every life, we can skip over that. Some facts about harm reduction, and Sarah alluded to this in her introduction, is that drug prohibition has a long history of being very intimately and intricately tied to colonization and white supremacy. There's a really great page from the Canadian Drug Policy Coalition on the history of drug policy in Canada. I think I put the link at the bottom of the slide. Can you see the link? I can't see it on your slide share, Sarah. That's weird.
The link is on the page. It just might not be showing properly on this.
Okay, the link is on the page. So if you want to see the link and read that page, it's a fantastic page and an overview of how drug policy has over decades been implemented to target specific racial groups within Canada. And something that we continue to do today. I want to take a moment to acknowledge, as Sarah did, that everything that we as healthcare providers know about harm reduction and about advocacy in the world of harm reduction, we have learned as a result of people who use drugs advocating loudly for what they have needed to stay safe and alive in systems that continue to ignore them. So I continue to learn daily from my patients how to recognize the shortcomings and the failures of our system, and how to stand up for demanding that change. I wanted to talk a little bit about the principles of harm reduction in healthcare. I don't know if this is going to be a bit too superficial or basic for a lot of the group here, but these are values that I hold very dear to myself in practice, and are things that I would encourage each and every one of you to reflect on, both in how you're probably already providing care to patients or clients or community members, but also what you should expect from your own healthcare providers. And if you aren't getting these things, that you have the right to ask for them. So all of us exist in these systems where we provide care, but we also receive care from these systems, and we have to continue to hold it accountable to being safe for everybody. I'm just catching up here with my slides. So the principle of humanism here, it talks about the fact that I, as a healthcare provider, have to respect and dignify each of my patients as an individual, and that moral judgments don't produce positive health outcomes. So I've yet to find a medical diagnosis that has shame listed as one of its effective treatments for improving outcomes. And I've not found that to be something that is ever effective in my clinic or when I'm on the street with my patients. Something that I always try to acknowledge is that people engage in behaviors for a reason. So any harmful health behavior provides at least some benefit to them. And I have to understand their motivations to engaging in this harmful behavior in order to help understand how I can support them as a physician. So usually I'll say something to my patients like, when you use alcohol, there's some benefit that you get from it, even if that benefit is temporary. Some people might drink alcohol for anxiety or grief, loneliness, boredom, spiritual pain, physical pain, trauma. Do any of those reasons resonate with you? And I find people incredibly insightful into understanding what drives them to seek an escape from reality. The reality is that a lot of our patients are suffering incredibly, and it makes complete sense to me that they want something to allow them to escape. But understanding this is kind of point A of the care map that I try to create with them. So for example, if someone is battling unresolved grief from the traumatic loss of a loved one, and they don't have any interest in making changes to their substance use or their relationship with substances, I can say, yeah, that makes a lot of sense to me. You're experiencing a lot of pain right now, but could I still provide them access to grief counseling or some other kind of a support? While that might help to meet some of that unmet need that's driving their substance use, it also just addresses the fact that they are a human and they are deserving of care and support, regardless of harmful behaviors or substance use or whatever moral judgments might fall on people as a result of being inside of our colonial systems of care. And ultimately, when you address some of those root causes, you provide harm reduction because you allow people to use their substances in maybe a safer, more controlled, less impulsive way. Pragmatism is an easy one, I think, for all of us to understand. If anybody has ever tried to lose 5 pounds or quit smoking or do 30 straight days of yoga or whatever it is that you try and are unable to do, none of us are ever going to achieve perfect health behaviors. And it's unreasonable for us as care providers to expect that. So health behaviors and the ability to change them are a result of social and community norms, and they are impacted by so many factors that are going on in somebody's life. So we never assume or prioritize that abstinence is the goal. So just like if I was trying to support a diabetic to get their blood sugars under control, it would be unreasonable of me to expect that a patient is never going to eat sugar ever again. But I can still support them to get things under control in a way that is reasonable for them. Individualism is another easy value. Everybody comes to the table with their own story, with their own strengths, their own needs, either met or unmet. And we have to be working with patients exactly where they are in order to provide them support. Autonomy. So the way that I usually explain this to my patients is that you are the driver of your health, and it's my job as your physician to provide you the menu of things that are available to you, and to talk about the pros and the cons of each of those things and help you make an informed decision. But ultimately, you're the person who makes these decisions, and I'm here to support you in whatever choices you ultimately make. Incrementalism is remembering that we have to celebrate all positive change and any positive change. So ways that I incorporate this into my practice is acknowledging the natural history and pattern of substance use disorders. For example, in my first or second time meeting a patient, I will give them my spiel about relapse, which starts by acknowledging that it will probably happen. And I don't say this to discourage my patients, but to take the chance to say that if or when relapse happens, that I hope that they can stop, give themselves a moment of grace and compassion, and not treat this as a failure. Relapses and slips are not personal failings. They're just a natural part of the course of this illness. And there are opportunities for us to learn from what happened, to reevaluate their goals and plans, and try to figure out if there was something that we can do to better support them with their goals in the future that maybe was missing this time. And so often my patients will end up having a slip or a relapse, as we all do in recovery, and they will come back to me and say, it happened, and I remembered you saying this to me, and I remembered that this is just what was expected, and I was prepared for it, and we had talked about who to call when this happens. And it's a way to acknowledge that too is a huge win, right? That's an incremental win when somebody has a slip and then recognizes that that's okay, and that they still stay on track with their recovery plan. I wish this is one that I never had to tell anybody, but we don't fire patients for not doing what we want them to do. That's never okay. I'm not sure what world that is okay, but physicians are not allowed to fire patients for living with the natural history of the disease that we are treating them for. So my patients know that when a slip happens, that doesn't mean that their prescriptions are going to change or their carries are going to change or their, frequency of appointments with me has to change unless they want it to. And I think that's a really important part of the relationship that I build with my patients. I wanted to take a few minutes to talk about the work that we're actually doing currently. Before I move on, maybe does anybody have any questions about, I haven't been following the group chat, so I'm sorry. I have not been following the group chat to see if there's any questions. It doesn't look like there are any. But does anybody have any questions about any of those basic theories of harm reduction in healthcare and about how we can maybe hold our systems accountable to incorporating those things?
I don't have a question. I just really want to just name some of the stuff that you just were talking about. Being a person with lived and living experience while also working in a lead role, it's always been really difficult to walk in both worlds. And I don't think I've ever seen a doctor name the systems of violence in the way that you have. So I want folks to take note here. We're not gonna, I think that, putting people on big pedestals is not helpful either. I think I want to show you the love and the appreciation that you deserve. And I want folks who don't have lived and living experience to take note of the way that Jess has shown up from a perspective of somebody who has spent years as a consumer of the system. And then of course, working in the system that I am, right? So the other thing that I just want to point out before we move on is how I've never heard anybody name the things that me and Jen name. Jen and I are both educators in our roles. And, I always say that all forms of revolutionary change is from people who are impacted by those systems of violence. And we've really lost in translation what it means to really show up and perform harm reduction work because it's been so long. And people seem to think that it's this, brilliant idea of like public health officials who had this idea to support people, but it actually probably wouldn't have happened if it weren't for people who use drugs, particularly racialized and queer people who use drugs. And there was one more thing that I was going to say. You also named something about safety, right? In our conversations as leaders and educators, we're often met with these questions around, what about the safety? What about our safety? What about the staff safety? Right? And it's like, why are we finding ourselves prioritizing our safety over the safety of people who we serve, right? It should be, equal value of safety, but unfortunately, because of the systems, it is going to be people who use drugs who don't experience the same kind of safety, right? They're not going to be given that. So thank you. I just wanted to point that out and for folks to take note of like, how do we show up as allies? How are we, really like coming back to the basics? How are we honoring the people whose trauma and labor kind of brought us to where we are today? Thank you. That's all I wanted to say.
Thank you, Heather. Thank you. I cannot agree more with you that we absolutely need to be naming the violence that happens in our healthcare system. We need to name it and we need to speak out and we need to call it when it's happening. And I think that as physicians, we have taken a very long time to come to this table. We've taken far too long to come to this table. And I can't speak to why that is. I've only been in practice for a small handful of years now, but I continue to see a lot of turning away from our marginalized populations in the healthcare systems that I work in, and a lot of work that goes into preserving image and patting people on the back for good work and good meetings. And meanwhile, racism and violence in our healthcare system is something that I see every single day that I work in my hospital. And one of the ways that I implement this into my own practice, to continue to hold myself cognizant of that violence and of that discrimination, is when I'm first meeting a patient. I don't know if there's anybody here, but there might be some people here who have at one point been my patient and probably heard this spiel. But when I'm meeting somebody for the first time in the emergency department or on the street or in my clinic, I will acknowledge it and I will say, I know that you are here right now because you're really unwell. And I want to acknowledge the reality that historically and still today, this has not always been a safe place for you to come to. And I want you to know that I am holding myself accountable to making sure that I am doing my best to make this a safer place for you. And I want to make sure that your pain is being taken seriously and that your concerns are being taken seriously and that I am hearing what you are needing to make this a safe experience for you. And I ask for that feedback from them to share with me if there's something that's happening to them that is unsafe. I am coming from a place of privilege, being a white settler in a position that society has deemed, my voice is given weight in our community, and so I have to use that privilege to try to speak truth to that. And I'm still learning the best ways to do that, but I appreciate, Heather, that you acknowledge that.
If I can just add one little thing to that, just since we're on the topic of safety, speaking kind of directly to the nurses and anyone who may be interested, in March, we are going to be hosting a webinar with some researchers who have been doing some concrete work around illicit exposure, illicit drug exposure within the healthcare setting, kind of debunking some of those myths around exposure and everything like that. So if you're interested, to join in on that. I thought this would be a complimentary preamble to that sharing of knowledge moving forward. So that is an important topic, at least here in BC, that's impacting, access to OPSs and pieces like that. So could serve to provide you some evidence-based information to share with your employers and teams. So I'll pass it back over to Jess if there's no other questions. There's just a few comments in the chat that we can address at the end if that works for you.
Okay, sure. I'll let you guys, I'll let you just keep monitoring that. If there are things that are timely to talk about, then I'm happy to be interrupted. Yeah, thank you. Thank you for interrupting me. That's so much better than anything that I could ramble on about. Just to speak a little bit about hospital-based OPS, I mean, this is such a low-hanging fruit that we all need to have at our hospitals in order to allow people who use drugs to access hospital systems equitably. But to speak just more broadly to OPS, and I hope that these are just some basic facts that you can take when you're hearing arguments against OPS. But there are some good studies that I refer to regularly that I put just under the picture here. This is a picture from our Nanaimo-based OPS on its first day, which was really a very cup-filling day of connection. But a study in The Lancet shows that there's a 67% decrease in drug-related deaths in the neighborhoods surrounding OPS. So that study shows that there is a relationship from how close you are to that OPS and the rate of decreased drug-related deaths. So it goes out, the 67% was seen in 500 meters surrounding the OPS, so half a kilometer in every direction, and then that sort of teetered off as you moved further outside of that 500-meter zone. But it goes to show that in a community like Nanaimo, I don't know if any of you are familiar, but we're a super long city all along the ocean, and we have one OPS currently that is not going to have that much of an impact to anybody in the north part of our city who might be using drugs. OPS massively reduce opioid-related emergency department visits and ambulance calls, which alleviates the burden on cost on our strained healthcare system. I know that I'm not speaking as an island here when I say that emergency departments everywhere are overwhelmed and overfilled, and police or ambulance drivers are overwhelmed with 911 calls. And OPS are a huge way to reduce that burden and save taxpayer dollars while also providing a more compassionate, evidence-based way to approach this crisis. Finally, the increases that we see within OPS to referrals to care. Communities that have an OPS, we see better referrals to things like treatment supports, recovery services than communities that don't have an OPS. And that's because a lot of the relationship forming, as I'm sure you all know, happens on the ground in an OPS. When you're sitting in a tent with someone and they've met their needs, they've used their substance, they're feeling safe because they're not worried about the cops coming around the corner. And they're in a space right now where they're feeling well, and there's a person right there who's not shaming them, who they can trust to talk about what support they need. So you all know this, but OPSs are such a place of forming relationship and fostering those connections with our most marginalized patients. And I see a lot of magic happen in them that is so undersold in how OPS are portrayed in the media. And then support for hospital-based OPS. I mean, a great study came out in 2022 from some physicians over, I didn't link it. I'll link that study. In 2022 from physicians over in the Lower Mainland in BC that shows that people who use drugs are 4 times more likely to leave hospital against medical advice. So against medical advice is a really shitty term that doctors have come up with to say that a patient is leaving when it's not what the doctor thinks is best. I have not yet found a term that I like. I mean, I don't like that term and I don't use it, but I would love if anyone has a better term than AMA that I can start using in my hospital charting.
Oh, I just was thinking, I just forgot about it now. I just had it and then I lost it. It was something we just started using. I'm sorry.
That's okay.
I just had
Patient-initiated
it.
discharge.
That's the one. Jen got it. Yeah.
Great.
Sorry.
Thank you, because I hate typing AMA. And even in this study, they used the term AMA, which I think we just didn't have a better word yet. But patient-initiated, self-initiated discharge, yeah, probably because we're not meeting their needs in the hospital and they're in pain and they're in withdrawal, and we tell them that they have to leave the hospital grounds and go and use in a bush when they need to go and meet their needs, because the medications that I have to offer often can't meet their needs. So when people have a self-initiated discharge, thank you so much for that new term, this leads to deterioration of whatever their acute health concern was that they needed to be hospitalized in the first place. It leads to increase in antibiotic resistance. Think about the wounds that we see in the community and how many rounds of antibiotics people get before those wounds clear up. And every single one of those, when patients are coming in and needing IV antibiotics in the hospital, if they're discharging AMA, every single one of those is an opportunity for the development of antibiotic resistance. And every time they deteriorate and come into the hospital and need a longer course of antibiotics because this infection has developed now into their bone, or they need surgery and then they need to recover from their surgery, or their pneumonia gets worse and then they're brought in and needed to be intubated in the ICU. Every single one of those things is a failure of our system to care for the people who need it the most. and a huge cost to taxpayer dollars and a huge burden on our system. And so even if you can't speak to people's desire to want to help our vulnerable patients, you can at least talk about the dollars, because the dollars speak for themselves. And sometimes I find when I'm speaking with politicians, I have to put more of an emphasis on that, but it's a huge cost to our system to have this.
There, in conversation regarding the magic that happens in the OPS. I just recently, Jess is smiling. I just recently had the pleasure of meeting a new client coming into AVI who informed me that his life was saved by the wonderful doctor at the OPS out by NRGH and had put him on a different path. Where that goes, it doesn't matter. What matters is it just spoke volumes to what it meant to him. And it just, I think we all need to know that too. Unfortunately, the ones who really need to hear it don't hear it, but just kudos to the great work everybody's doing. And you too, Jess. Yeah.
Thanks, Sheila. This is, and I know it says Melissa Bowie here, but these are a bunch of my really amazing colleagues at AVI, where I have the privilege of working here in Nanaimo. A fantastic, passionate group of people. Thank you for sharing that, Sheila. Does anybody have any specific questions about hospital-based OPS? Otherwise, I really want to open it up and hear people's thoughts and concerns and have more of a conversation.
Yes, there was one question in the chat from Carly Hood. I can read it to you if that's easier.
No, I'm looking right here.
Okay.
To assist with advocacy efforts, is that it? Yeah. Is there any data/research articles that you found particularly helpful sharing with healthcare stakeholders that are new or skeptical with implementing harm reduction care models? Thank you in advance. Yes. So part of a lot of, and it's specific to OPS, but a lot of it applies to harm reduction as well. Oh, this picture, isn't this such a cute picture? So this is Dr. Ryan Harriet. He's one of the doctors down in Victoria and one of the co-founders, along with me and Dr. Kelsey Roden, for Doctors for Safer Drug Policy. And that is his child, Elwin, who came and hung out with us and ate all of our snacks and brought their bike. And we had a great OPS day that day. It was our one sunshiny, non-bomb cyclone day of OPS. It was great. But to get back to Carly's question, so that's a fantastic question, Carly. And that's something that I've found in speaking with MLAs, MPs, city councillors, mayors, is that they have a lot of power over what we get to have access to in the harm reduction world, and they have no idea what they're talking about. And it's a really scary thing that our politicians have as much power over the tools that I have access to as a physician, and that all of you have access to as clinicians. And so I've put together a Google Drive of the evidence about hospital-based overdose prevention sites. So it takes 3 peer-reviewed studies, but I acknowledge that many people are not good at reading peer-reviewed literature. And so I've highlighted the basic things in each paper. And I'm like, if all you read is those highlighted points, you will understand the gist of the paper. I've put in a few other important, quick, easy things to read. And the goal is that somebody can go through this Google Drive in 10 minutes before a meeting with me and have the basic foundations of what they need to understand why I'm asking for hospital-based OPS. I've done my best to put it in language that is easy. I'm not carried away with the statistics because that's something I'm personally not very good at. So I take the easy statistics from it and try to pass those on to the politicians and the other organizations that I'm speaking with. I'm very happy to share that. I don't have it with me right now, and I'm not quite good at Google Drive enough to get it quickly, but I will get it emailed out to everybody. And then please feel free to use it.
I'm just gonna stop sharing the slideshow now unless there's anything you want to touch back on.
Do you want to maybe just click forward one more slide? Because then there's
yeah.
there's like our contact information there. So Instagram, Facebook, most of the time, if you reached out to those social medias, you're going to get me. I'm mostly the person who's navigating our social media. Sometimes Ryan Harriet is on Blue Sky. And then if you want to just shoot us an email, it's that Gmail down at the bottom. Jenny, did you just share the Google Drive? Oh, amazing. Thank you. There's one paper in there that's missing, which is the study from the Lancet that I cited. I don't know how it fell out of there, but I will put it back in, and then everybody has that link to use. So please feel free to pass that on as like a nice little like edible size piece of harm reduction that you can shove down their throats.
And I'm happy to send out the slides, the Google Drive, and whatever other resources come out when we get this video posted. I'll send it out to all the registrants so you have that. And if there's anything else, just let me know. I can do that too. But I'll stop sharing now so we can see faces and have more of a chat with everyone. So if anyone has questions or comments, feel free to turn on your audio and ask directly, or just put it in the chat.
I just wanted to quickly share, like, while we're on the topic of, I guess, convincing the efficacy of harm reduction, we can also talk about the funding federally. When I can figure out my tech stuff, I can share the link, but there's this horizontal Canadian Drug and Substances Strategy report that came out, I think it was 2023, and it showed that out of all the federal budget that was towards substance use, 8% of that budget was harm reduction, and 58% of that was law enforcement. So when you really think about it's quite insane. I think people get really baffled at that, because I think people often say, oh, it's a waste of taxpayer dollars, stuff like that. And it's really clearly from that report, that's, I think, the latest, is there's nothing compared to the way that we fund police, right?
Yeah, ew. That's a great study. I would love to get that. RNAO presented annotated bibs of research on OPSS to our Associate Minister of Health prior to the decision to close the SCS in our province. We shared the importance of an integrated approach to harm reduction and provided the evidence. That work fell on deaf ears. Unfortunately, we must continue to persevere. Yeah. It's falling on a lot of deaf ears. And a lot of the politicians that we're speaking with still have a shameful level of ignorance around this crisis that we've been in now for a decade. Yeah, I don't know what the answer is to that, other than continuing to join together in collective action and continue to be loud. Unless people have some specific thoughts that they want to share, I'd love to just reflect back on those questions about safety in our healthcare systems that I asked at the beginning, and something that I think I've acknowledged and I will continue to acknowledge is that physicians have been completely absent from this conversation, and we have not been using the voices that we are privileged to have to make change happen. And I hope that that starts to shift, but I'm still learning, and I'm always all ears on how we can be continuing to do better. So if anybody now or in the future at any point ever has feedback